That's right, folks. Welcome back to JKLIVE here at Citizen Television. Two of my favorite doctors, experts in when it comes to COVID-19. Dr. Lois Ombajo, infectious disease expert at the University of Nairobi, and Dr. Gidenji Gitahi, he's Group CEO, Amref Health Africa. Both have been here before. We've talked about this situation. We're back again. Looks like the numbers are rising again. Dr. Ari, 12.5% positivity rate. Is this a sixth wave?
Thanks, Jeff. So it probably is a sixth wave. If you think about the last few months, around March, April, our positivity rate was about 0.2%, sometimes even 0.1%. We closed most of our COVID units. We didn't have any patients in hospital with COVID-19 for quite a few months. So over the last month or so, we've begun to see more cases. And as you've seen in the daily reports, a few hundred people diagnosed with COVID every day. So definitely there's a bit of a wave. And a wave basically means there are more cases than we've been saying. So there's a bit of a wave, yes. The COVID units that were closed, we're beginning to have to open some of them and admit a few more patients than we've seen in a long time.
Yeah. Dr. G, you agree?
Completely agree. You see, when we talk about a wave, as Dr. Ari says here, it's just an increase in positivity. It's an increase in number of people who are positive for COVID in a population. So basically you're saying from the previous lull, we had 0 people in 100, almost statistically. 0.1, we were very low. So you could say that in a group of, you needed about 200 people to identify one case, or more than 200 people to identify one case. Right now, you need only 100 people to identify 10 cases. You need 10 people to find a case, from 200 people to find a case. So, of course, there is a wave. What is interesting is, of course, that this positivity has a much lower severity than previous waves. So, as Dr. Ari says, we are not seeing as many people in the hospital as we did in the previous waves. Right. But we are seeing people in the hospital as well, still. But when we define people in the hospital, we must also say that the hospital has two sides. The hospital has an outpatient and has an inpatient side. So the number of people who are going to the outpatient is very high because people are getting severe sore throat, cough, fever. They end up in outpatient. A fewer people ending up in the inpatient. Does that mean that doesn't matter? No, it matters, because even going to the outpatient, it costs you time, costs money, costs resources from the health system. But also interesting, Jeff, to note that in all the previous 5 waves, we had a gap of about 3 to 4 months, wave to wave. Right. We've had a gap of 6 months. Okay, which tells you that actually this thing is going to be with us for a very long time. Because initially you could say these 3 waves are maybe a population that didn't completely clear, then it starts again. You know, it's almost like bushfires. When the fire has not completely gone off, then the bushfires keep coming up. But 6 months tells you that actually the virus is settled. It's almost like it's going to be here with us for the future. That's what I read from the gap.
Dr. Lois, what variant is this? Is this Omicron? Is it Delta? Is it what is it? Do we know?
So Omicron is sort of the variant that we began to see towards the end of last year. So around October, November, and most of December, we had the Omicron variant. So the way these variants come is that the virus changes itself a little. It changes what it looks like so that it can avoid the immune system. So occasionally it changes significantly and we end up with a new variant. Sometimes it changes just a little and we have what we call a sub-variant, which means it retains a lot of the characteristics of the initial Omicron, but there are some small changes therein. So what we're seeing now are sub-variants of the Omicron. These sub-variants have been discovered in other parts of the world. For example, the current sub-variant that we're seeing has been causing a bit of an outbreak in South Africa, for example. So then we begin to see it in the country. And during this, a lot of the time when we're seeing just sporadic 1 or 2 cases, many of them are from people who had traveled or interacted with people who had traveled. But as that becomes more frequent, then you have it now being transmitted to people who've not really traveled. So it's a sub-variant of the Omicron. It still looks like the Omicron. And maybe that's a good thing for us because we know that Omicron caused milder disease. People did not end up requiring oxygen or in critical care. And it's the same sort of situation that we're seeing now, that a lot of people are getting sick and a lot of people will tell you they've had a cold or a running nose or a sore throat. A lot of people are missing, children are missing school because they have some infection. People are missing work because they're feeling sick. But a few of those people are ending up very sick, requiring admission into the hospital.
Right. Yeah. Dr. G, could it also have to do with the weather? You know, June, July, usually cold months. A lot of people have come down with, colds, regular flu.
Yeah, you see, the thing is that it's kind of playing on each other. So let me put it this way. During the cold season, what other people call winter, our cold season, is that during the cold season you have a higher prevalence of viral respiratory infections affecting the nose, the throat, the chests. They basically rise. Now, that could mean two things. That the virus itself, the coronavirus itself, is having a much better environment because of the temperatures, but also that if you have a common cold, you're more likely, if you have a coronavirus, to transmit it. Because you know behavior, people are blowing their noses, they're coughing, they're touching their nose, and people have lost the public health measures that we advise to continuously sanitize and this kind of thing. So it's kind of, even if somebody has a cold and then ends up with a coronavirus, it's more likely that that person will transmit it because they're also touching their nose more frequently because of the common cold. So it's kind of all those factors together. So the common cold, the weather pattern has a contribution to it, because even in other countries that have winter, we see surges during winter. Mm-hmm. Just like the flu. Yeah. It's more common in winter.
Right.
Yeah.
And actually, maybe the other thing to just put in, very true, in the cold season, other than biologic factors that make the virus multiply a little more within the airways, you also have people are huddled in rooms and closed all the windows, and people are spending more time together in closed environments, and that's good for transmission. During this last few weeks, when we've seen a lot of colds and all, there's been, yes, a lot of COVID, but we've also seen a bit of flu, influenza virus, and other viruses as well. And that's not surprising. Often, again, spread of many of these viruses may happen in times such as this.
I'm glad you mentioned closed environments. What about people in public rallies?
Yeah, I don't know. I'm not as worried about people who are out there where there's, wind and sunshine. They're probably not as likely to transmit and catch it than if we're sitting in a small room and there's 10 of us and you're sniffing and I'm coughing and someone else is sick. That is an environment where you're probably more likely to transmit than for someone who's out there. And again, I guess some of the things that have happened in the recent past, after the mask-wearing mandate was dropped, people went back to normal, which is a good thing because life needed to continue. But now it means we need to be wiser. When we see things are getting worse, then we think about, when I'm in a room with other people, should I wear my mask?
Coming back to your Swiss cheese analogy, Dr. Ari, we dropped the mask. Did you drop the ball as well?
Well, I think as has been said here, the tools we have for control of coronavirus, not only coronavirus, but also other diseases, have to do with the effectiveness of the tool, depending on the time, okay? So if you have 0.1% positivity, meaning that only 1 in maybe 300 people are likely to have the virus at that point, then the mask is less important at that point because you are less likely to meet somebody who is positive. And because the mask has a cost to yourself as an individual, because it costs money to buy it, to the fines that are imposed by the court, it's a cost to society, to environmental cost because of disposal, then you weigh the benefit versus risk. And you say, because the benefit of the mask at this positivity is lower than when positivity is higher, let's drop the mask. But when positivity increases, we return the mask. So you use the tools within the Swiss cheese model as and when you need them. But the tool that you need to continuously use is vaccination, because then that is the ultimate tool. Because then you change, you see all these other things, when you're washing your hands, you're wearing your mask, you're protecting yourself from the virus coming in, okay? But the vaccine is changing what we call the hosts situation. It is empowering the hosts, which is the body, to fight the virus. So that one you don't change, you just need to tell people get vaccinated. But masks, you use them when you know they have the maximum benefit. But of course, hand washing has maximum benefit all the time because it's not only COVID, it's protecting you against diarrhea and other things, and pneumonia and everything else. Yeah. So you do that all the time.
Dr. Lewis, there's some people who got vaccinated twice and even got the third boost. but they've gotten the recent cold. How is that?
So that's an interesting question. So one, we know that vaccines are not 100% in preventing infection. They're very good in preventing severe disease, which means if you get infection, you're less likely to get very ill. But again, the other thing is that as the virus changes and we have new variants, some of the variants may, we say, escape from the immunity that was brought about by the older vaccines, which means vaccines have to continually improve in order to protect against new variants as they come. So yes, globally, we've seen that phenomenon. People who've had a booster, even 2 boosters, still getting the infection. And I think the biggest benefit we have is that you're less likely to get the most severe infections. And I think based on that, as different countries roll out vaccines, we can actually have a staggered approach. So that in countries where you have the highest rates of COVID and highest numbers of people getting very sick, then it's imperative that you roll out the vaccines as soon as possible to the largest number of people in the population, and that may include children and others. Yeah. In contexts like ours, where we have lower levels of infection, lower rates of severity, and lower deaths, then it means that where you need to roll out the vaccine rapidly is to protect those who are most vulnerable. So even in a situation such as this, those who are older, who have certain other conditions that make them at risk for getting severe disease, it's important that they're vaccinated. And it's important that resources are directed towards getting these people who are most vulnerable, because that's where you get the biggest return for the investment of vaccination. Yeah. So again, even as we go out, make sure that those who are most vulnerable get the vaccination.
Dr. G, I saw you on TV the other day rolling out a mobile vaccination unit.
Yes.
How was the response to that, first of all? Are people apathetic? Are they willing? Are they...
Yeah. You see, the reason for this mobile vaccination unit, or we call it a movable vaccination unit, because it's not a vehicle, it's a towable unit that you can take to different places, is because of experiences that we had in our vaccination outreaches. In Nyeri County, which is now having actually the highest vaccination rate, ahead of Nairobi at 53%, we went out as AMREF together with our partners, and we were doing what we're calling moonlighting. We are taking the vaccines to the people at night, social places. You know, we find people where they're sitting having, nyama choma, and we set up. And that had a very high acceptance rate. Then one time we went to Kibera, and we have a clinic in Kibera, and that clinic vaccinates 15 people a day, Monday to Friday. Remember that our facilities only open vaccination 10 to 4. And then after that, they close, and they don't start before 10. Now, when you look at a community like Kibera, people wake up very early. These are strong people, wake up and go to industrial area, and then they come back in the evening. So if you're opening 10 to 4, they don't have a chance. They would have to actually choose not to go to work to come for vaccination. So when they're on a Saturday, and we had so many people, we had to close vaccination by midday. We said we are not registering any more people. We vaccinated close to 400 people in 6 hours at the same site where we vaccinate 15 people a day. So it occurred to me and to us in the ecosystem that the challenge of vaccination is not hesitancy. The challenge is actually convenient access. That because the risk perception is low, you need to take the vaccine to where the person is, where they work, where they live, where they play. And that is why the mobile vaccination or the movable unit came up. And we have seen, when we were launching it, we vaccinated close to 100 people in a very short time. So the acceptance is very high, and it is because of one factor, convenient access to the vaccine. So people are not going to abandon their daily living activities to go look for the vaccine. But if the vaccine finds them conveniently, they'll accept it. That's why we have rolled out these mobile units.
Do we have enough vaccines in the country?
Yes, we do. We have actually more vaccines than we can roll out on a daily basis. Right now, we are rolling out maybe 10,000 a day. We have enough vaccines to get back to where we were at 100,000 a day. Yeah.
Well, Dr. Lois, is this going to be like, how we used to get the annual flu shot? Is this what it's going to boil down to?
That's an interesting question. I think one of the things we know with COVID is after all this time, which is 2 years, we're still learning a lot of lessons around COVID. So it's really difficult to tell whether 5 years from now we'll still need to get an annual shot. I think this is one of those where we take it a day at a time and we learn along the process. What we know is that the initial vaccines may not protect against the current, may not offer adequate protection against the current variants. So there has to be lessons learned and very rapid uptake of vaccines that can protect against emerging variants. So if more variants emerge, then definitely more boosters will be required. But I think it's probably too early to tell. I don't know if you have an answer to that question. I don't have a good answer to that question.
Well, I think that is actually a very complex question, Jeff. And the complexity of this question goes beyond COVID. I think what COVID is telling us now is we need to be ready for new viruses, for emerging viruses, for re-emerging viruses. And this is going to, therefore, make all of us accept vaccination as our end game in protecting ourselves. Look at monkeypox now. You know, monkeypox has been with us since 1970 in Africa. Thousands of people have got monkeypox. Countries like DR Congo, Nigeria, whatever, have been responding to monkeypox. Suddenly, it's now going to beyond the African borders. Now, look at Ebola. It comes, disappears, then comes back. Yeah. If you look at the track of emerging and re-emerging viruses between the year 1970 and now, the new viruses and re-emerging viruses are more frequent, whereas they used to emerge after 10 years. Now they're emerging every year. There's a new pandemic of a new virus or a re-emerging virus. Basically, we are saying that not only in COVID, that we are in a scenario now, in an era where we have to expect that we are going to have repeat vaccinations of new viruses, old viruses. COVID is not going to go anywhere. It probably becomes a shot every 2 years or 3, but there will be new viruses that we have to be prepared for. So we have to accept this as a future norm. And this is really because of climate change.
It boils down to climate change.
It boils down to climate change, population growth, interaction of people and animals. We have to start to know that the diseases that affect animals are going to cross over to human beings more and more because, you know, if you look at the domesticated animals now, cows, cats, dogs, we've domesticated them over several centuries. So we have actually become, we are no longer naive to their viruses that infect them. Our bodies have become used and our genes have adapted to the viruses that infect the already domesticated animals. But now we are eating bats. You know, I saw on TikTok somewhere a Kenyan who is eating bats, you know? Can you imagine? We are now getting into wild animals where our bodies are completely naive to the viruses that infect them. Now they are going to now cross over to human beings. And that we are seeing that more and more often. Population growth, infringing on where wild animals live, consumption of wild meat. Yeah. So this is the norm in the future.
There's another young man eating a dog the other day. He was caught, he was arrested for slaughtering a dog.
And it's a domesticated animal.
So it might be safer, but a bat, somebody eating a bat. You know, the coronavirus.
Did you just say it might be safer?
It might be safer, you know, exactly. You know, it might be safer. I don't recommend it, but it could be safer.
Right.
But I heard actually one of the presidential candidates saying they're going to be exporting dogs as well. So I think this is a debatable point.
And snakes.
And snakes as well. But let's not get into politics. No. But that's health. That's actually not politics. That is health. But if you look at COVID and the origin of it and the conversations around it, it is actually animals that are not domesticated by human beings that are starting to be consumed. It is all those animals that are interacting with the people in the Wuhan market that were found there. So it is actually crossing over. If you look at Congo, Ebola relationship with the human beings, monkeypox, all these things, they're coming from the wild and crossing over to human beings where the human body is naive to the immunity of how to fight a new virus or bacteria that comes into it. So this is the future with flooding, with population growth, with deforestation. So we have to be prepared to this recurrent vaccination.
Dr. Lois, both you and Dr. G were here last time and you spoke about something called herd immunity, right? Have we able to achieve that here in Kenya yet?
So, I mean, we hope that herd immunity comes from vaccination, and that was our hope at the time that vaccines were rolled out.
Yeah.
Sometimes herd immunity will come because a lot of people have been infected. That's a situation you don't like for something that you don't know about, because a lot of people could get very sick. Having said that, in December of last year, we had probably the entire population, would be my guess, getting infected with Omicron.
Yeah.
And for that reason, there was some immunity in most of the population. And that may be part of the reason why we've taken quite a few months before we've seen another wave coming up. But the thing about this immunity is now we know that it wanes or reduces over time. So that if you've just had COVID or you've just had a vaccine, your immunity levels will be at the highest. But over the next several months, they'll begin to reduce to a point where you can get another infection. So again, with a virus that changes over time, it means the concept of herd immunity has to also, the understanding around it has to change because of the issues of now requiring to revaccinate. It means achieving herd immunity now is no guarantee about what will happen in a year's time, because that immunity reduces over time.
Dr. G, you agree?
I agree completely. And I think that, of course, I don't have any studies to back this. And I think Dr. Lois is making an important point that the delay between the last wave of Omicron, which we thought was the largest mass vaccination of people on COVID, natural mass vaccination, the delay to this sixth wave of 6 months could actually be reflective of the people who got their immunity from infection waning. And the people who got it from vaccination takes longer than the people who get it from natural infection. That could be actually the reflection of the 6 months. Of course, studies need to be done, but I think it has something to do with it, that those who got the Omicron but not vaccinated, the immunity is waning, and now that's where we have this sixth wave. That could be possible.
And I understand a lot of young people are getting infected with this so-called flu, but there is no vaccination for young people yet out here, right?
Yeah.
There is now. I mean,
ages?
Now we've had Pfizer approved for 15 years and above, and we have more than 360,000 between 15 and 18 already vaccinated, fully vaccinated, okay, in this country. Yeah. Of course, we have a big population there, so we wish there were more. But today, I think maybe yesterday or today, the Kenyan National Advisory Group on Vaccines has approved for us to go down to 12 years. For vaccination. So anyone now from 12 years can actually get vaccinated. And that's now policy of the National COVID Task Force. Yeah.
And the vaccines, can we still do a mishmash or mix and match like we were doing the last time, or you stick to one?
So again, in this same advisory of KENITAG, what we call KENITAG, the advisory group on vaccines, they have recommended that you can actually mix and match. But the primary vaccine, the primary regimen that you find, if you decide it's AstraZeneca or J&J or Pfizer or Moderna, the primary regimen needs to be the same. But the boosters can be mixed and matched. Okay. And that's the advisory.
So the first two have to be the same?
They need to be the same.
Okay.
I mean, most of the data that we have to inform this were where the first and second vaccine were the same. Yeah. But we also have data to suggest that if you get an alternate booster, so if you got AstraZeneca as your primary vaccines and you end up with a Pfizer or Moderna, that probably that immunity is higher than if you end up with the same vaccine booster. Yeah. So for the boosters, it would be recommended that you get a different type.
Yeah.
By the way, this latest variant, what are the symptoms basically? What are they?
So most people have been complaining of sore throat, a headache, they may have a fever, a few people have a running nose and a cough. And that's what we've seen for many of the patients. So it's just that flu, it's the usual symptoms of an upper respiratory tract infection with a lot of sore throat, a lot of fatigue, maybe some aches here and there. Just from the symptoms, you really can't differentiate between the COVID-19 or any of the other viruses that we've seen. Yeah.
Doc, there's some people who got COVID back in 2020. And they're still suffering from what some people call long COVID. Is it long COVID or long-term COVID?
Long COVID.
Long COVID. Yeah. Well, it is, the reality is that there are people who got the infection, and because the infection, depending on the severity, some of the symptoms remain for a long time. I have a friend of mine who got COVID and was in HDU for almost 3 weeks, and every time he gets a flu, even if he's negative for COVID, he needs oxygen because his lungs were already compromised, and therefore, he needs more care on a normal flu than somebody who didn't get COVID before. Of course, Dr. here in the front line, the clinical front line, can comment more on the long COVID, because even Kenyatta National Hospital is establishing a long COVID clinic, so maybe she can comment on that.
So yes, we did have a post-COVID clinic. Over the period of January to May, when we didn't have too many patients, we ended up not having any patients coming to the post-COVID clinic. But when we had patients, I think most of what we saw is, one, people who've had very severe disease and a lot of damage to the lung may take a bit of time to get back to their normal function. So they'll still get short of breath when walking. They may require oxygen for a little longer. Many times that tends to reduce with time. So these symptoms reduce with time. We have patients who have just chronic fatigue, some who have joint pains or muscle pains or, aches here and there over a long period of time. But from what I have seen, and people may have different experiences, is that most of these symptoms tend to get better with time. So I think it's around just encouraging someone to try and get back to normal activity, to get back to exercise if they can, and keep living, because now we can't live and be held back by previous COVID. So to get back to being active, engage in whatever social activities are involved in, exercise as much as is possible, and that may help them get back to normal faster.
Exactly. And maybe to add to this is that there is recently, in a few months now, there are cases of childhood hepatitis or inflammation of the liver in Europe and North America. And some scientists are relating it to previous COVID infection, and that the antibodies that were developed by the COVID infection creating inflammation of the liver, and it's being seen in children who are under 5. So the long COVID could actually, show itself in multiple ways, and that is why the most important thing is to protect yourself before the infection by getting vaccinated, because then you don't want to suffer the post-effects of an infection. You want to protect your body by building its immunity to protect yourself from any severe current or future what you call sequelae of the disease.
If someone got a third booster about 3-4 months ago, should they go for the 4th booster? Or are they ODing?
The recommendation of Kenitag, again, and I would like to hear Dr. Lois's view, is, of course, if you have had your booster, it's the booster, it's the full vaccination plus the first booster. Then if you're high risk, Kenitag is recommending that you go for a second booster. The high risk could be people who have, other conditions, cancer, hypertension, diabetes, and people who are elderly. There's a recommendation that they should actually go for the second booster.
I think this is something that, again, there needs to be a bit of learning around it. The data to support second boosters is still not much. So again, it's around sort of saying we're getting repeat waves. What does that mean? If immunity is waning, do we need to get another booster? But I think we still do not have sufficient data to support repeat boosters. And I think time will tell us what the best way to go is. In many other countries, we've seen them encouraging people to get repeat boosters. But as I said, again, responses will have to be targeted and relevant to the context in which they're put in. If you go to Europe, for example, they've had very high mortalities. They have a larger elderly population. So again, the thought of repeat boosters, given the rates of COVID that they're seeing, may be relevant. So I think we have to tailor some of our recommendation based on the situation in the country.
Sure.
Exactly. And that's why the Kenitag is recommending specifically the second booster for the high risk, those above 60 years, not as a mass recommendation. Yes.
Okay. Folks, I want to take a break, come back and ask the question. Look, people are being told to wear the mask again. I see you both came in with masks, but you go out there, nobody's wearing masks. How do we re-emphasize that? How do we reinforce the mask wearing habit? Because there's some people, even my colleagues are saying, there are people saying that. Are we going to go back to that? And again, it's your layers. It's this Swiss cheese formula, of putting layers. What are we going to do going forward? All right, and a lot of questions from viewers. Lots of questions and comments, so keep them coming. At Koinange Jeff, at Citizen TV Kenya, the hashtag JKLIVE. We've got Dr. G in the house and Dr. Lois to tell you any question you need that has to do with COVID. These guys are the experts. We'll take a break. We'll be back in a moment.